Imagine starving a patient for 12 hours. You give them absolutely nothing by mouth. Then you just wheel them into an operating theater and subject their body to the massive systemic trauma of major surgery.
Yeah, it sounds completely counterintuitive now, but for decades, that was just the unquestioned gold standard of care.
Right. We now know that approach basically forces the human body into a state of metabolic panic. It's essentially causing it to cannibalize its own skeletal muscle just to survive the procedure.
It's a perfect example, I think, of how deeply entrenched medical dogma can be and, how radically things can shift when we finally look at the underlying physiological mechanism.
Absolutely. Welcome to today's deep dive, everyone. We are digging into the 4th edition of the Oxford Handbook of Clinical Surgery, which details several of these massive shifts.
It really does. In fact, the preface of this text highlights what the editors call a cataclysmic change in the profession. They trace it back to a very specific milestone.
Which was the first laparoscopic cholecystectomy, right? Performed at their trust back in 1992.
Exactly. The removal of a gallbladder using minimally invasive cameras and tiny instruments instead of a massive open incision.
In reading through the handbook, you really see how that single innovation sparked a total revolution in minimally invasive procedures. But it also had this unintended, almost paradoxical consequence.
Yeah, it led to the decline of traditional general surgery because suddenly every surgeon had to hyper-specialize to master these incredibly complex laparoscopic techniques.
We basically traded broad, generalized surgical capability for astonishing technological precision.
We did. But the authors of the handbook raise a crucial point for anyone entering the clinical environment today. Whether you are manipulating a state-of-the-art robotic arm from a console across the room or holding a traditional scalpel in your hand, the bedrock of surgical success remains unchanged.
It relies entirely on mastering core principles, everything from cellular physiology to the ethical framework of how you actually communicate with the patient.
Right. And that is the exact mission of our deep dive today. We're going to treat this session like an audio textbook tailored for medical students, young professionals, and intensely curious learners.
We will extract the most vital practices and pathologies from the handbook. We'll cover the ethical duties of a doctor, the literal language spoken in the operating theater, and the mechanical frameworks for diagnosing specific surgical pathologies.
So I think the most logical place to begin is before the surgeon ever steps up to the operating table, because technical brilliance in the theater is fundamentally useless and highly dangerous without a solid ethical grounding.
That makes sense. The text talks about the General Medical Council, or GMC, outlining the baseline duties of a doctor using the 3 C's: competency, communication, and correctness.
Right. And correctness is also referred to as probity.
Yeah, when you first read those words, competency, communication, correctness, they sound a bit like generic corporate HR platitudes. It is so easy to just skim past them.
Oh, totally. But applying them to a surgical setting transforms them from abstract ideas into literal physical realities.
So it's like the operating system of a smartphone. If the ethical and communicative operating system is buggy, the surgical apps, like the physical procedures, will ultimately crash and fail the patient.
That is a great analogy. For example, correctness or probity isn't just about being polite. If a surgeon lacks probity, they might cover up a minor slip of the scalpel during a procedure.
Wow, yeah. And that lack of ethical correctness directly translates into a silent, lethal postoperative bleed.
Exactly. The physical consequences of ethics are profound. Consider communication and trust. Trust is not merely a social construct, it is a physiological imperative.
Wait, how does trust become physiological?
Well, a patient who is terrified, who does not understand their procedure, and who lacks trust in their surgeon will experience a massive spike in cortisol and adrenaline.
Right. And high cortisol levels actively suppress the immune response and delay wound healing.
Precisely. Clear communication literally improves the biological outcome of the surgery.
That completely reorients how we should view informed consent. If communication impacts physical healing, then consent cannot just be a legal signature on a piece of paper.
No, it can't. The handbook details 5 highly specific elements a patient must understand for consent to truly be informed. First, they must grasp the nature of their illness, like the actual reason for the procedure.
Okay, that's step 1. What's the second?
Second, they need to know exactly what the physical procedure entails, down to the size of the scar and whether they will wake up with plastic surgical drains stitched into their abdomen.
Right, because managing those physical expectations is critical to preventing that postoperative cortisol spike you mentioned.
Exactly. Third and fourth, the patient must understand the risks. The handbook divides these into risks specific to the operation, like ending up with a permanent stoma, and general risks of any major surgery.
And a prime example of a general risk is developing a deep vein thrombosis, right? Like a blood clot in the leg caused by prolonged bed rest.
Yes, very common. And finally, the fifth aspect. The patient must be informed of the alternatives, including the physical consequences of choosing to do nothing at all.
Okay, here is where I have to pause and push back a little, because explaining risks brings us to the handbook section on evidence-based surgery and surgical statistics.
I know where you're going with this.
Yeah, if I am lying on an operating table, I frankly care about the steadiness of the surgeon's hands, not their ability to do math. I've never fully understood why a surgeon needs to act like a statistician with concepts like Gaussian distributions and confidence intervals.
It is a common frustration, I get it. But statistical literacy is actually the only way a surgeon can ethically fulfill that informed consent requirement.
How so?
Well, when a surgeon tells a patient this new procedure has a 5% lower risk of complications, they need to know if that number is a universal truth or just a statistical fluke from a flawed study.
Ah, okay, so the Gaussian distribution, the classic bell curve, helps them determine this.
Right. If you measure the blood pressure of 10,000 healthy people, most readings cluster tightly around the mean, the average, right in the center peak of the bell.
And as you move toward the extremely high or extremely low blood pressures, the curve slopes downward because fewer people exhibit those extreme values.
Exactly. And the width of that bell curve is defined by the standard deviation. A tight curve means everyone's physiology is behaving similarly. A wide, flat curve means the results are chaotic and spread out.
So by calculating the standard deviation, researchers derive the 95% confidence interval.
Yes. This tells the surgeon that if the study were repeated 100 times, they can be 95% confident the true average result will fall within a specific range. Without that mathematical certainty, a surgeon is just guessing with a patient's life.
Wow. That really makes the math a prerequisite for the medicine. You cannot honestly look a patient in the eye and explain their surgical risks if you don't understand the confidence interval of the data you are quoting.
You really can't. And that heavy burden of knowing the exact physiological truth brings us to probably the most solemn clinical duty covered in the text, which is defining and confirming death.
Right. In the UK, there is no single statutory definition of death, so it relies heavily on clinical markers indicating the irreversible cessation of circulation and respiration.
The parameters are very exacting. A doctor must observe no respiratory effort and no palpable pulse for 1 full minute. They must verify no response to painful stimuli and observe fixed dilated pupils.
Why specifically 1 full minute of no pulse?
Because the brain is incredibly metabolically demanding. It consumes roughly 20% of the body's oxygen supply. 1 minute without circulatory blood flow initiates an irreversible ischemic cascade.
Oh, so the cells just run out of power.
Exactly. They exhaust their tiny reserve of ATP energy, their cellular pumps fail, and they begin to swell and die.
The handbook also includes a glaring warning regarding the pupil assessment. It says beware of drugs like atropine. So if you are assessing the pupils, you have to know what chemical agents the patient received during resuscitation.
That is so critical. Atropine is an anticholinergic drug. It artificially blocks the parasympathetic nervous system.
The network responsible for the body's rest and digest functions, right? Which includes constricting the pupils.
Yes. So when atropine blocks those signals, the pupils dilate widely and remain completely fixed.
So if a doctor doesn't realize atropine was administered during a code, they might look at those chemically locked pupils and prematurely declare brain death. That would be a devastating misdiagnosis.
It would be catastrophic. So moving from the heavy reality of life and death, we shift our focus into the operating theater itself. To survive and function in this environment, you have to decode the language.
Yes, surgical terminology can look like an intimidating wall of jargon, but the handbook treats it like a skeleton key. The words are really just composite codes built from basic Greek and Latin roots.
Exactly. Once you have the key, you can decipher any operation. The first part of the word typically identifies the anatomical organ. Lapar refers to the abdomen.
And chol points to the bile system or gallbladder, while masto indicates the breast.
Right. And then the suffix dictates the physical action taken upon that organ. Otomy means to cut something open. Arectomy means to physically remove it.
Ostomy is the creation of a new, permanent, or semi-permanent opening. Endoscopy means to look inside using a camera.
So applying that skeleton key makes complex terms completely transparent. Take the procedure cholelocdocoduodenostomy.
Okay, let's break it down interactively. So chol is the bile system,
Yep, and docho means duct.
and duodeno refers to the duodenum, the first section of the small intestine. And adding ostomy at the end tells us the surgeon is creating a new opening.
Put it all together, and it is a surgery to bypass a blockage by creating a direct connection between the bile duct and the small intestine.
That is so much easier to grasp. Fluency in that language is essential as you participate in theater protocols, particularly the patient preparation phases.
Which brings us back to what we touched on at the very beginning with the concept of fasting. The handbook dedicates significant space to ERS, that's Enhanced Recovery After Surgery.
ERS represents a massive paradigm shift in managing the physiological stress of an operation, specifically by overturning that nil by mouth from midnight dogma.
It really does. Pre-optimizing the patient under ERS involves giving them clear, carbohydrate-rich drinks up to 2 hours before the induction of anesthesia.
See, this completely violates the traditional fear of a patient aspirating stomach contents into their lungs while unconscious. I struggle to see how feeding a patient moments before surgery is deemed safe.
It's all about understanding stomach emptying times versus metabolic demands. Clear liquids, including these specific carbohydrate drinks, transit through the stomach incredibly quickly, usually within 2 hours.
Making the aspiration risk practically zero.
Exactly. But the metabolic benefit is immense. When you starve a patient for 12 hours and then cut them open, their body registers a catastrophic threat. It triggers a profound, acute catabolic response.
The body literally believes it is simultaneously starving to death and being physically attacked.
Precisely. In a catabolic state, the body frantically breaks down its own skeletal muscle and tissue stores to liberate rapid energy. It floods the system with stress hormones.
But by administering a carbohydrate load shortly before surgery, you basically trick the metabolism into remaining in a fed anabolic state.
Exactly. The body does not panic. It preserves muscle mass, maintains insulin sensitivity, and heals significantly faster post-operation.
That is a brilliant manipulation of basic physiology. ERAs also strongly advocates against routine bowel preparation, right? Like the heavy administration of laxatives to clear the colon before abdominal surgery.
Yes. Flushing out the intestines severely dehydrates the patient. It causes wild fluid and electrolyte imbalances and strips away the natural gut microbiome.
Which actually leaves the bowel wall more vulnerable to nasty postoperative infections or leaks at the surgical joints.
Exactly. Another non-negotiable protocol designed to protect the patient from harm is the WHO Surgical Safety Checklist. Before a single incision is made, the entire surgical team must pause.
Right. They verbally confirm the patient's identity, the exact procedure, the operative site, and the functional status of all equipment.
It is directly borrowed from aviation pre-flight checklists.
What strikes me is the psychological mechanism behind it. The checklist forces everyone in the room to introduce themselves by name and role. It actively flattens the traditional, rigid medical hierarchy.
Which is so important. If a junior scrub nurse notices the senior consultant is about to operate on the wrong limb, that nurse is much more likely to speak up and stop a catastrophic error if they were just formally acknowledged as a critical part of the team.
Human factors engineering at its finest. Once the checklist is complete and the procedure begins, a surgeon's success depends entirely on their understanding of what they are cutting into.
Absolutely. Anatomy and pathology dictate the physical approach. The handbook provides vital frameworks for this, beginning with how we classify tumors to determine if a cancer is even operable.
The text outlines two distinct systems for assessing malignancies: staging and grading. They sound interchangeable, but they measure entirely different properties.
Yeah. Staging uses the TNM system, which operates like military reconnaissance. It maps out the physical location and spread of the enemy.
Okay, so T assesses the physical size and local extent of the primary tumor.
Yeah.
N indicates whether the cancer cells have marched into the regional lymph nodes.
Right. And M stands for metastases, checking if the cancer has established distant outposts in organs like the liver or lungs.
So TNM staging is like military reconnaissance. But grading is more like psychological profiling, figuring out how aggressive and chaotic the individual enemy soldiers are.
That is a brilliant way to put it. Histological grading requires a pathologist to examine biopsied tissue under a microscope to assess cell differentiation. A grade 1 tumor is considered well differentiated.
Meaning the cancer cells still roughly resemble the healthy tissue they mutated from, right? They maintain some structural order and divide somewhat slowly.
Exactly. But a grade 4 tumor is highly malignant.
Because more than 75% of the cells are undifferentiated. Under the microscope, they have lost all specialized structure.
Yeah, they have massive chaotic nuclei. They don't look like breast cells or colon cells anymore. They just look like primitive, aggressively dividing anomalies.
So a grade 4 tumor requires a vastly different surgical and oncological approach than a grade 1.
Absolutely. And understanding the mechanics of pathology is just as vital for structural failures like abdominal wall hernias.
Right. A hernia is defined as the abnormal protrusion of a viscus, usually a loop of bowel, through a weakness in the wall that is supposed to contain it.
The handbook heavily contrasts two types of groin hernias, inguinal and femoral.
Inguinal hernias are far more common, pushing through the inguinal canal, and they affect men dramatically more often than women at like an 8-to-1 ratio.
Yes, due to the anatomical pathway left behind when the testes descend during fetal development. But femoral hernias, which push down into the femoral canal, carry a massive surgical warning.
Which is?
They have a remarkably high risk of strangulation.
And strangulation happens when the blood supply to the trapped bowel is choked off, causing the tissue to rapidly die.
Yeah.
Why is the femoral canal such a dangerous trap compared to the inguinal canal?
The femoral ring, the entrance to the canal, has incredibly rigid, unyielding boundaries. It is bordered by the dense inguinal ligament, the pubic bone, and the tough lacunar ligament.
So it physically cannot stretch.
Right. If a loop of bowel sneaks through that tight ring and swells from venous congestion, those rigid walls act like a guillotine on the delicate arterial blood supply. The tissue becomes ischemic and necrotic within hours.
Wow. The text also describes a variation called a Richter's hernia, which is conceptually terrifying.
Oh.
In a typical hernia, the entire tube of the intestine folds into the defect, blocking the passage of food.
But in a Richter's hernia, only a small portion of the intestinal wall, specifically the antimesenteric border, gets pinched in the defect.
So the danger lies in the masking of symptoms. Because the entire tube isn't blocked, the intestinal lumen remains open.
Exactly. The patient might still pass gas and have normal bowel movements, presenting without the classic signs of a bowel obstruction.
Meanwhile, that pinched portion of the bowel wall is actively strangulating and dying, ready to perforate and cause lethal peritonitis.
It really demands an incredibly high index of clinical suspicion, and surgeons navigate these treacherous anatomies using eponymous landmarks, which are areas named after the pioneers who mapped them.
Like going back to our hook about the laparoscopic cholecystectomy. A surgeon cannot safely remove a gallbladder without meticulously dissecting Callow's triangle.
Callous triangle is a vital anatomical space. The boundaries are the common hepatic duct on the left, the cystic duct on the right, and the inferior border of the liver forming the roof.
Navigating carefully into this triangle is the only way to positively identify and clip the cystic artery. Right, preventing the surgeon from accidentally severing the main bile ducts and causing lifelong catastrophic complications.
Exactly. Another essential landmark is McVerney's point. It's the classic diagnostic location for acute appendicitis.
It sits exactly 1/3 of the distance along an imaginary line drawn from the anterior superior iliac spine, the bony front point of your hip, to your umbilicus.
And these eponymous rules also extend to clinical deductions, such as Courvoisier's law.
Oh, this one is fascinating. This law states that if a patient presents with jaundice and a palpable, painlessly distended gallbladder, the underlying cause is highly unlikely to be gallstones.
Right. It is much more likely to be a malignant obstruction, such as a slow-growing pancreatic tumor.
The mechanism behind Courvoisier's law is a great lesson in chronic versus acute pathology. Gallstones are usually a chronic condition. Years of stones rattling around cause chronic inflammation and scarring.
So the gallbladder wall becomes severely fibrotic, thick, and shrunken.
Right. So if a stone suddenly drops into the main duct and backs up the bile, causing jaundice, that scarred gallbladder physically cannot stretch.
Conversely, if the obstruction is a slow-growing tumor in the bile duct, the gallbladder itself is perfectly healthy and pliable.
As the bile slowly backs up over weeks, the healthy gallbladder wall acts like a balloon, expanding massively until it can be easily felt through the abdominal wall. The physical compliance of the tissue tells you what the disease is.
It's just elegant clinical deduction. Finally, our journey through the handbook concludes with a critical look at surgical populations, specifically emphasizing pediatrics. The foundational mantra here is, children are not small adults.
Their baseline physiology requires entirely different parameters, like a neonate's normal resting pulse rate is between 120 and 160 beats per minute.
Paired with a remarkably low systolic blood pressure of 40 to 50, their total blood volume is so small that losing a few tablespoons of blood is the equivalent of a massive hemorrhage in an adult.
which is why all fluid replacement and drug dosing must be meticulously calculated based on exact body weight. The handbook also provides a chilling warning about assessing shock in children.
Right. Because a child's sympathetic nervous system is so robust and highly reactive, their bodies compensate incredibly well for fluid loss. They clamp down their peripheral blood vessels and drastically increase their heart rate to maintain cardiac output.
But that compensation masks the severity of the crisis. Because their stroke volume, the amount of blood pumped per beat, is relatively fixed, tachycardia is their only defense mechanism.
Exactly. Tachycardia and delayed capillary refill will be your primary indicators of distress. Hypotension, a drop in blood pressure, is a very, very late sign of shock.
So if a doctor waits for a pediatric patient's blood pressure to fall before initiating aggressive resuscitation, the vascular tank is already empty and they are likely too late.
It is a profound reminder of the stakes involved.
So let's synthesize this comprehensive sweep through the surgical landscape. We built our foundation on the tangible consequences of the GMC's 3Cs, exploring how ethical probity and informed consent directly modulate a patient's physical stress response.
We justified the necessity of statistical literacy to prevent surgical guesswork and detailed the ischemic mechanics behind confirming clinical death.
We then unlocked the language of the theater with our Greek and Latin skeleton key and explored how ERA's protocols manipulate human metabolism to avoid catabolic panic.
We moved through the risk-mitigating hierarchy of the WHO checklist, mapped the spread and chaos of cancer through T&M staging and cellular grading, and detailed the rigid anatomical traps of femoral and Richter's hernias.
Finally, we navigated by the stars of Cowles' triangle and McBurney's point, deduced pathology through the fibrotic mechanism of Courvoisier's law, and highlighted the deceptive compensatory mechanisms of the pediatric cardiovascular system.
As we step back from this massive density of information, I want to leave you with a provocative thought regarding the future of the field.
I'm ready. What is it?
We opened by discussing the cataclysmic change brought about by laparoscopic surgery in the 1990s, which caused a decline in traditional general surgery. Today, we are crossing the threshold of another cataclysm.
The integration of autonomous robotic surgery and AI-driven diagnostics.
Exactly. As algorithms and robotic arms increasingly take over the technical and cognitive load of these procedures, a critical vulnerability emerges. How will the next generation of surgeons develop and maintain the tactile physical diagnostic instincts?
Right, like the ability to feel the fibrosis of a gallbladder or the tension in a femoral ring.
What happens when the power grid fails, the network goes down, or the technology simply isn't available?
It really is a question of whether we are augmenting our capabilities or just outsourcing our core competencies. It's a lot to think about. And as promised for our dedicated medical students and self-taught learners, we have a short review exercise to solidify today's deep dive.
Get a piece of paper ready. First, utilizing the Latin and Greek skeleton key we discussed, write out the exact anatomical definition of the surgical procedure pyelolithopaxy.
Consider the roots for the renal pelvis, a stone, and the physical action of crushing. Second, sketch a diagram of Cowles' triangle and clearly label its 3 specific anatomical boundaries.
Check your answers against your textbooks to ensure you are thoroughly prepared for the clinical wards.
Thank you so much for joining us, and keep diving deep.